So, good morning, everyone. Today, we're going to discuss about the topic mental deficiencies. So, hi, I'm Dr. Akash Chaudhary. I'm third year resident of Psychiatry Department of Bharati Medical College. So, first, what's in the name? So, previously, the patients who used to suffer from intellectual disability were previously called as idiots, morons, feeble-minded, mentally retarded, and now the current term that we usually use is intellectual disability. This was given by American Association on Intellectual Development and Disabilities, is the basic guidelines that we usually follow for somebody to define us as an intellectually deficient patient. Definition: deficient in IQ and adaptive functioning. IQ of 70 or below, measured by standard scales such as Wechsler's, Stanford-Binet, and Kaufman. Impairments in adaptive functioning, which comprise of effective coping and common life demands. They'll be requiring assistance from the family members in day-to-day functioning. It depends on the severity, how somebody is mentally disabled, that how much support that they need from the family members. Ability to meet standards and independence. Are they able to do things independently, such as doing household chores, or will they be able to activate in the occupational activities or not? Again, it can be measured by standard scales such as Vinland Adaptive Behavior Scale. So, intellectual disability, the prevalence in the population is 1 to 3% of population. It has been found to be slightly more in males as compared to females. It is more prevalent in lower socioeconomic status and in minority groups. Patients who don't get the adequate care when they are born, as people who might be getting home delivered due to some problems in their economic statuses, they are not able to reach the hospital care. The propensity or the probability that they might be suffering from any acquired infections or appropriate postnatal care is quite high. So that is one of the causes that the patient might be intellectually disabled. Especially for mild intellectual disability, no differences for more severe levels. Now comes the degree of severity. So we term them as mind mental retardation when the IQ is around 50 to 55 to approximately 70. So these are the different IQ scales, and then we define the patient as mild, moderate, severe, or profound. The government also gives various benefits to the patient depending upon how severe the mental retardation is. So mild mental retardation when the IQ on the scale comes out to be 50 to 55 or around 70. Moderate mental retardation when IQ is 35 to 40 or 50 to 55. Severe mental retardation when IQ is in the range of 20 to 25 to 35 to 40. And profound mental retardation when IQ is less than 20 to 25. The proposed classification based upon the intensity of supports needed as opposed to IQ. So traditionally we depend on the IQ a lot, but there is another adaptive scale through which we can differentiate if the patient needs the severity, which can be intermittent support, limited support, extensive support, or pervasive support, is the amount of support that the patient's required. First, mild mental retardation, previously referred to as educable. They were called as educable because they could be taught several life skills through vocational training or through special schools in which they'll be able to take care of their basic needs. It comprises of the larger segments of those suffering from mental retardation, about 85%. So if 100 people are suffering from intellectual disability, 85% of the population lies into mild MR. Typically develops social communication skills during preschool years, minimal impairment in sensory motor areas, often indistinguishable from typicals until later age. So initially their development will be quite normal to adult children. They'll be able to attend schools, but the first symptoms that the family usually start to figure out is that they have not been performing academically so appropriately according to their age. So that's the first time that they reach out to us. By late teens, acquire skills up approximately to 6th grade level. So basically, if the patient is intellectually disabled and has been diagnosed, then there's a limited amount of adaptability or the IQ that the patient might be having. So it all depends how much the deficit is, and the maximum that they can acquire is up to 6th grade of education. Now comes moderate mental retardation, previously referred to as trainable. So first was educable, now it's trainable. That they won't be too much into studies, or will they be able to study up to any grades is quite questionable. About 10% of those with MR most acquire communication skills during early childhood years, generally benefit from social vocational training, and with moderate supervision can attend to personal care. Difficulties recognizing social conventions which interface with the peer relations in adolescence. They will have difficulty where to say, what not to say. They'll have difficulty in having social interactions with people in social circles. Unlike to progress beyond the second grade academically, often adapt well to life in the community in supervised setting, performing unskilled or semi-skilled work. So they basically need a continuous supervision and a special areas where they'll be able to do some community setting social skills or vocational training. Now comes severe mental retardation. 3 to 4% of those with MR acquire little or no communicative speech in childhood, may learn to talk by school age, and be trained in elementary self-care skills, can master sight reading, survival words, able to perform simple tasks as adults in closely supervised settings, most adapt well to life in the community, living in group homes or with families. So basic survival words such as food, water, if they want to go washroom, they'll talk to you in monosyllables, whatever need that they require. But later on, other things they are not able to communicate well, as the tendency to have those comprehension skills is quite low. Then comes profound mental retardation. It is 1 to 2% of those with MR. Most have an identifiable neurological condition that accounts for their MR. So a basic underlying organicity is found in these types of patients. Considerable impairments in sensory motor functioning. Optimal development may occur in a highly structured environment with constant aid. So again, the attention, the amount of training required, and the specialized environment required is quite high as compared to other severities of mental retardation. So these are a basic schematic diagram showing the different features of mild, moderate, and severe profound intellectual disability. So IQ range first, then percentages of cases, ability of self-care. In mild, they are independent. In moderate, they need some help. And in severe and profound cases, their self-care is quite limited. Language development in mild is quite reasonable. They'll be able to communicate their daily needs, even able to crack jokes or watch movies and have a conversation. As moderate, there is limited, and in severe, there is basic or none. Reading and writing, reasonable again. Moderate is basic, and severe, minimal or none. Ability to work is semi-skilled. They'll be, for example, they'll be able to do work as a waiter in a restaurant, but they won't be able to handle more complex skills. I'm talking about the mild ones. The moderates are unskilled and need supervised training. Same with the severe cases. Social skills are normal in mild cases. Physical problems are rare. Etiology discovered sometimes. Academic skill level 6th grade or higher. So mild MR patients would be there quite a lot in the community, and we won't realize that they're suffering from mental retardation. There was this case who was of bipolar affective disorder in my first year, who had MR, but he was able to communicate properly, was able to do household chores, was able to do different things. But when we did his IQ score, it came out to be mild intellectual disability. And then it is very important for us as well to, so that patient doesn't get misdiagnosed, that we are thinking that there is some behavioral problem and we are giving them some medications. And the prognosis also depends on the development of the mind and their trainability. So what the IQ the patient has. Suppose we are patients, family members come to us, they are saying that he doesn't listen to us, gets angry very easily, we are not able to take him out to the social settings, but he's able to take care of himself daily, he's able to go outside daily, he's able to, milk the cows, he's able to go to the gym as well, but still they might be having some underlying pathology of intellectual deficits. So it's very challenging for us as well, and it should always be kept in mind while you as doctors will be going out in the community to see if the family members arrive to you and they say that he's been able to go to school and there was no problem till 5th or 6th grade, then completely ruling out MR is not advised. So it should always be kept in mind that the child might be suffering from mild or moderate intellectual disability. Psychiatric disorders associated with intellectual deficit Prevalence higher than general population, delusions, hallucinations, and obsessions may not be easily recognized in people who have limited language development and cannot describe them. More emphasis is given to the behavior. Lower the IQ, greater the difficulty in diagnosing psychiatric disorders. So patient is having intellectual disability and they are superimposed having some psychotic symptoms, but the language difficulty is so prominent that we are not able to elicit those symptoms. So it is very difficult for us to diagnose a patient simultaneously who is suffering from intellectual disability with any other psychiatric illness. Most commonly associated disorders with intellectual disability could be ADHD, schizophrenia, mood disorders, pervasive developmental disorders, stereotypic movement disorders, mental disorders. Schizophrenia. So the prevalence in the patient who have already been diagnosed of intellectual disability is 3%. If the IQ is less than 45, it is difficult to diagnose schizophrenia. In these cases, the diagnosis of psychosis NOS should be considered. Rather than we fully blown diagnose them as F20 such as paranoid, we go for psychosis NOS. It is a subcategory of schizophrenia in which the symptomatology and the behavior is quite similar to schizophrenia, but the patient does not have persistent hallucinations, delusions. So we keep these patients in psychosis NOS category. Sub-individuals display presumptive evidence of response to hallucinations. Example, striking or shouting at empty spaces, throwing imaginary peers from furniture, or adopt catatonic postures that can appear to be psychotic in origin. Like we are not able to elicit any auditory or visual hallucinations, but the behavior is quite hallucinatory, that they might be talking to the walls, throwing things at something. So this is one way of seeing the symptomatology of the patient. Some of the symptoms of underlying brain damage, such as stereotyped movements and a social withdrawal, may wrongly suggest schizophrenia. So, patient might be having some organicity. Patient might be having difficulty during the childhood brain development. There might be some deficit, and the patient comes with the stereotypical movements in which there is a regular shaking of hands, or patient has stopped talking to the family altogether. So, the misdiagnosis of schizophrenia might also happen. It is always necessary to compare behavior before and after the onset of susceptible psychiatric disorder. So patient is intellectually disabled. We know the patient is intellectually disabled, and now the family comes to us and tells us that he's been behaving abnormally. He's not talking to us, is getting angry on trivial issues. So first it's necessary for us to ask the normal mood, and when he was perfectly all right, apart from being diagnosed with intellectual deficit, was everything behaviorally he was normal or not, and since when the family has started observing these behavioral symptoms. Mood disorders, depression diagnosis has to be made mainly on appearance of sadness, changes in appetite and sleep, and behavioral changes of retardation or agitation. Mania has to be diagnosed mainly from overactivity and behavioral signs of excitement, irritability, or nervousness. So these are basically the things that we keep in mind if the patient is suffering from mood disorders. If he's having depression, there might not be a cause or underlying psychosocial stressor before developing depression. So we have to see, basically depends on the mental status examination of the patient. Anxiety disorder frequent at the time of stress. Post-traumatic stress disorder have been reported in people with ID who have suffered physical or sexual abuse. Patients of intellectual disability sometimes are taken advantage of in the society, both male or female, as they know that whatever complaints they go and tell to their parents or family members, it is very hard to establish that they have been sexually abused or wrongly done, both physically or violently. So post-traumatic stress disorder have been reported in patients with intellectual disability. So careful history taking is really important. Common symptoms of anxiety in the population with intellectual disability include aggression, agitation, compulsive or repetitive behaviors, self-injury, and insomnia. Panic may be expressed as agitation, screaming, crying, or clinging. So, for example, a patient comes to you, like patient comes to us who's diagnosed with intellectual disability, and then they complain of that he's having aggression, he's getting agitated on trivial things. So it is very important for us to keep in mind that straight away not go to jump the diagnosis as patient might be manic or be psychotic. There could be underlying anxiety which they are not able to express. So this is their way of communication. Eating disorders. Pica is perhaps the most common eating disorder among persons with intellectual disability. Overeating and obsessive features of Prader-Willi syndrome. So in Prader-Willi syndrome, it is quite common that the patient is hyperphagia हो जाता है उन लोगों को. Prader-Willi syndrome is very important for your NEET examinations as well. They always ask this question in which what is the pathology and what is the cause. So there's this silencing of these genes. So both the male and female, whatever genes you acquire from the family members, normally one of those genes gets silent. So if both of those genes get silent, then Prader-Willi syndrome comes to us. They also have difficulty in the development of their mind. So these are the eating disorders which might be presented to you. So if patient is being diagnosed with intellectual disability and there's hyperphagia, then chromosomal or genetic study is also necessary to rule out Prader-Willi syndrome. Dementia, adults with Down syndrome are more likely to develop dementia than general population if they have been diagnosed with Down syndrome, as they also fall in the category of intellectual disability. If their IQ is not appropriate, then the probability that they'll be suffering dementia as their age is quite high. ADHD, the rates of ADHD in individuals with intellectual disability are estimated to between 9 to 18%, which is quite high. Diagnosis of ADHD is based on developmental considerations, namely hyperactivity, impulsivity, and inattention, significantly greater than that expected for a given developmental age. And thus the threshold for diagnosis in persons with severe to profound intellectual disability should be elevated. So what we usually see is patients usually come to us that the child is not sitting at one place. He keeps on roaming around, is quite restless, touches everything, does not sit at all. And this number of 9 to 11% could be underreported. Patients usually have this restlessness and anger irritability symptoms who are diagnosed with intellectual disability. So diagnosing them with ADHD is also necessary, as the treatment line is quite different to just giving them behavioral symptoms for behavioral changes, as ADHD might require methylphenidate or atomoxetine, super supplemented with low dose antipsychotics. Oppositional defiant or conduct disorder, about 30% of young people with mild to borderline intellectual disability, more in males, not applicable in non-verbal children with the more severe level of ID. Oppositional defiant disorder or conduct disorder is usually diagnosed in patients such as symptoms as not giving, they don't respond appropriately to the authorities. The school will keep on complaining again and again that they are behind mischiefs every day. They skip schools. They don't follow the rules. So it is the propensity of diagnosing patient with oppositional defiant disorder or conduct disorder is quite high in patients suffering from ID. Tic disorders can be difficult to differentiate from stereotypic movements and self-stimulating behavior, particularly when the patient is non-verbal and cannot explain that the tic is a response to an irresistible urge, which can however be delayed. Tics such as facial grimace or vocalization are usually less complex body movements and do not appear to be intentional as in the case of stereotypic movements. So how does the patient of tic disorder represent? Like the child is sitting inside the class and abruptly he starts abusing. And then he again comes back to normal. He keeps on saying that the intention of me of abusing or making sound is not intentional, but they continuously make those sounds. So that's how basically a case of tic disorders present to you. So what are stereotypic movement disorders? Persistent, driven, non-functional motor behavior which interferes with the daily activities or causes injury. Requiring treatments occurs in 2 to 3% of young people with more severe levels of intellectual disability. Pervasive development disorders, about 75 to 80% of children with autism also have intellectual disability. Autism is associated with high levels of emotional and behavioral problems and the burden of care. The diagnosis of Asperger's disorder is excluded by the presence of mental retardation and delayed and deviant language development. They can be differentiated from those who have autism because they show an ability and interest to communicate, use gestures and imitations, show an interest in reciprocal and imitative play, interact responsively with emotion in a manner appropriate to their developmental level. So the patient who are suffering from autism disorder have difficulty in social interactions with everybody. So if we are basically diagnosing patient with autism, the patient don't maintain eye contact. They are not interested in even communication at all. But the patient who have intellectual disability are interested in communication. They are also looking forward for a regular cooperative play. So comorbid autism should be diagnosed if the patient is suffering from intellectual disability. So what are the predisposing factors? No clear etiology can be found in 75% of those with mild MR, 32% of those with severe impairment. Specific etiologies are more often found in those with severe and profound MR. No familial pattern, although certain illnesses resulting in MR may be heritable. Hereditary 5% of the cases. Autosomal recessive inhibitor errors of metabolism, example Tay-Sachs or phenylketonuria. Single gene abnormalities with Mendelian inheritance and variable expression, example tuberous sclerosis. Chromosomal aberrations, example Fragile X. Early alterations in embryonic development in 30% of the cases, like chromosomal changes in Down syndrome. Prenatal damage due to toxins, example maternal alcohol consumption or infections. Environmental influences, 15 to 20% cases, deprivation of nurture and social, linguistic and other stimulations. Mental disorders, autisms and other. Pregnancy and perinatal problems in 10% of cases, fetal malnutrition, prematurity, hypoxia, viral and other infections. General medical conditions acquired in infancy and childhood, infections, trauma or poisoning during their postnatal age. At least 500 causes not known of what causes intellectual disability. Over 150 MR syndromes have been related to X chromosome abnormalities. Most common causes of mental retardation are Down syndrome. Most common Fragile X syndromes account for 40% of all X-linked syndromes. Fetal alcohol syndrome, most common attributable cause, which may predispose a patient of MR. If the mother is alcoholic, then the propensity of the child is quite high to develop MR. Together, these three account for 30% of all the identifiable cases in MR. Causes of intellectual disability, prenatal causes are 4 to 28%, natal 2 to 10%, postnatal 3 to 12%, and unknown causes are more than 50%. So these are basically what I just talked about: chromosomal disorders, single gene disorders, adverse material environmental influences, such as, so this is quite important, adverse material or environmental influences, iodine deficiency, folic acid deficiency, using substances such as alcohol, exposure to other chemicals, pollutants, heavy metals, harmful medications, infections, example torch and HIV infections also lead to mental retardations in patients. Postnatal brain infections such as Japanese encephalitis, bacterial meningitis, cretinism, gross understimulation, severe or prolonged malnutrition. These are basically the syndromes associated with intellectual disability: Down, Fragile X, phenylketonuria, Williamson, Prader-Willi, DiGeorge syndrome, Hunter syndrome, Hurler syndrome, Leishman syndrome, galactosemia. In my personal opinion, all these diseases are quite important. All of them. They'll be asked you in any competitive exam that will go into. What is the cause? What are the symptomatology? And what is the deficiency of an enzyme or a gene? So it is like if 15 diseases are written, expect at least 10 or 12 to come in your examination. All of them are very important. Not just in relation to MR, the other presentation, how these patients present to you. All the genetic causes is quite important. The diagnosis comprises of intellectual functioning and adaptive behavior in a mentally retarded, as assessed using a combination of stress and schedules. The important are measurement of the overall level of general intellectual functioning, assessment of adaptive behavior, and developmental assessment. The IQ test for diagnosing of intellectual disability comprises of Wechsler's preschool and primary scale of intelligence revised, Wechsler intelligence test for children 3, Wechsler adult intelligence scale review,
Stanford Binet Intelligence Scale 4th edition. In India, the tests are taken up basically in verbal tests such as Binet Kamar test, Binet Kulsestra test, Mallin's intelligence test for Indian children, non-verbal and performance test, which includes developmental screening test, Raven's progressive matrices, sanguine form board test, Gazelle's drawing test, post block design test. Common measures of adaptive behavior. Basically, we measure the adaptive behaviors of the child if the child is not able to cooperate through the verbal skills to assess not just the IQ but general adaptive behavior to assess the level of dysfunction. It comprises of Vineyard Adaptive Behavioral Scale, age range from birth to 18 years. Domains tested in this scale are communication, daily living skills, and socialization. Coping skills, AAMR Adaptive Behavioral Scale, Lambert and Nihira. Age range from 3 years to 18 years old. Domain tested independent functioning, physical development, economic activity, school, motor skills, which comprise of fine and gross. Scale of independent behavior revised, and Binet-Simmons scale Hindi adaptation for age groups of 2.5 to 18 years. Treatment modalities. In order to develop an appropriate treatment plan, an assessment of age-appropriate adaptive behavior should be made using developmental screening tests. The objective of these tests are to determine whether development milestones have been missed. The primary goal of treatment is to develop the person's potential to the fullest. Special education and training may begin as early as infancy. Attention is given to social skills and to help the person function as normally as possible. It is important for a specialist to evaluate the person for coexisting affective disorders that may require treatment. Behavioral approaches are important in understanding and working with the mentally retarded individuals. So in this slide, we are basically seeing that the early we diagnose the patient who's suffering from a mental disability, it's easier for us to train the patient in the same way as these kinds of schools, which are there for empowering the mentally disabled children, help them to cope up with the difficulties that they are currently facing and how to communicate with the social environment. Medications. Treatment for mental retardation depends on the type of illness. In mild, you may only need limited intervention and medication to manage these symptoms. For more advanced cases, considerable treatment and therapy is required. Medications are used to improve symptoms, but they cannot cure the underlying cause. So once you've been diagnosed with intellectual disability, in whatever the category it may be, it is almost impossible to reverse the symptoms as the damage has already been done to the during the brain development. So the only domain that we can treat through medication is the behavioral problems. Some commonly prescribed medications include antidepressants, anti-anxiety medications, mood stabilizers, antipsychotic medication, and anti-epileptic drugs to treat seizures. One common thing that we should keep in mind is that the dose required is way less as compared to giving to a normal adult. Not just because the patients are adolescents, but the susceptibility of developing side effect in patients whose brain have not developed properly is quite high. Antipsychotics, the typical antipsychotics have long been prescribed for disorders other than psychosis in patients with MR, including aggression, hyperactivity, antisocial behavior, stereotypies, and spatial. The atypical antipsychotics are now being increasingly used because of the belief that they carry a decreased side effect profile as compared to the first generation antipsychotics, as they have increased propensity to cause extrapyramidal side effects.